All right, next I'd like to introduce Dr. Judith Liu, who is a pediatric otolaryngologist at the other Washington University. It's in St. Louis, oftentimes confused with our University of Washington. She has really built a career on fabulous, rigorous clinical research, and she's really developed a body of work on the outcomes of kids with unilateral hearing loss, whether it's single-sided deafness or maximal conductive hearing loss. In my world of pediatric otolaryngology, when we think about unilateral hearing loss, Dr. Liu's name is almost synonymous nowadays. So she's going to talk to us about, for the first talk about causes of unilateral hearing loss and then outcomes later this morning. Thanks.
Thanks, Kathy. It's a delight for me to be here, and I'm just so thrilled that there's so many people who are interested in this topic. When I got started a little over 10 years ago, people really had lots of questions. Is this really worth really looking into at all? And I'll talk a little bit more about that. So the etiology is interesting in that, conductive hearing losses we can do something about most of the time, not all the time. For temporary hearing losses, such as from miliary effusions with otitis media, cerumen, earwax impactions, we can obviously do something about that and take care of that, and that's temporary. Tympanic membrane perforations can be fixable, but there can be situations where you want to delay actually repairing those, or a chronic suppurative otitis media, cholesteatoma, succular malformations, otosclerosis, tympanosclerosis. All of these are problems that we could do something about, but sometimes we delay doing something about surgically because of other medical reasons, because of the development of the child, their ability to cooperate with treatment. So even though conductive hearing losses are theoretically fixable, there may be prolonged periods of time where we actually allow that to continue until they reach a point where it is a good time to actually do something about it. So this is still germane, even though, again, most people think of these as, we can take care of these and we can make them go away. Now, oral atresia or an absent ear canal is the one situation where the patient comes into the office and I know immediately what's going on. That's not true with the rest of these etiologies or causes of hearing loss. So this is a nice picture that I picked up off of the web, looking at the spectrum of macrocious severity. And I'm sure many of you have seen these. Parents maybe have not seen these, but you can see a child even walking down the street or in the mall, and you can tell when these children are there, they have small ears and with variable deformities. And again, this is the one situation, especially if they have absent ear canal, when you know almost right away what's going on and probably what the degree of hearing loss they have. That's not necessarily true with almost every other child that comes through your office. So I'm going to spend the majority of my time talking about sensorineural hearing loss, but again, the conductive hearing losses are still something that we have to consider, especially if they're going to have them for a long period of time. So I started out with temporal bone abnormalities. This is probably the most common reason that children have sensorineural hearing loss, and it incorporates approximately a third of all kids overall. And there is definitely increased incidence if you have a child with severe to profound unilateral hearing loss. What's also very, very common is what's called the enlarged vestibular aqueduct or endolymphatic sac. And that terminology is variable, and it depends on whether or not they got a CT scan or an MRI scan. I'll go a little bit more into that as I show some pictures later. Cochlear dysplasias, that is malformations of the cochlea, are also quite common. Mondini deformity is one that you hear a lot about. Vestibular malformations are also quite common, and although we often don't pay attention to a unilateral vestibular malformation, they can have implications on a child's balance. It's really hard in a toddler. Are they just a toddler and falling over, or do they really have a problem with balance? And so this is something that has yet to be looked into more as we learn more about these kids. Cochlear nerve aplasia, hypoplasia, and a narrow internal auditory canal are kind of one of the same thing, again, depending on whether they're picked up by a CT scan or an MRI scan. And there's really a lot of interest in the implications of these findings in sensorineural hearing loss. There's also quite a number of etiologies, causes from different infections. And I start out with CMV. So CMV is congenital, is cytomegalovirus. And this is one of those infections that can happen in utero when a baby is developing. And we have a sense that this is probably an undiagnosed large population of kids with unilateral hearing loss, but we don't know the exact numbers because we don't have a good program across the country where we can epidemiologically follow them in the population. Meningitis is also a very important cause of hearing loss in one ear, particularly pneumococcal infections are important. Haemophilus influenza is also used to be an important cause. It's less important now because we've had now the H-flu vaccines for some 35 years now, and so that really has changed the way that we look at meningitis in kids. Labyrinthitis is still an important problem. Labyrinthitis can be from a variety of etiologies, whether it's viral or bacterial. And so we always have to think in our head, is this a possible cause of an acquired hearing loss? Ramsay-Hunt syndrome is a sequela of, or that it's a follow-up infection that can happen in kids who've had chickenpox. And so this is one of the reasons why if kids haven't gotten their chickenpox vaccinations, it is of concern to us. Trauma is obviously a big one in kids. You've got kids who are riding bikes, who are doing sports, who are very active, jumping off monkey bars. They are so prone to falling down, hitting their heads, and then having a temporal bone fracture. And this is an important cause for hearing loss as well. Concussions are also a concern, especially the more severe concussions that can happen in sports. It's not common, but I've definitely seen kids who had bad concussions and then are found to have hearing loss afterward, especially in one ear. Surgery is another important cause of hearing loss that is acquired, especially kids who've had history of cholesteatoma surgeries or potentially ossicular reconstructions for otosclerosis, and they have had complete hearing loss afterwards. So this can't be discounted, and that risk has to be considered as we talk about doing surgeries for elective purposes in children. And finally, medications are also a very important cause of hearing loss in kids. Aminoglycosides has been obviously something that's been around for a long time, and people are very aware of that. But I think the burgeoning interest right now is there are so many kids who are survivors from childhood lymphomas, leukemias, and other malignancies. And they're no longer dying, but they've gotten some very toxic medications, especially cisplatin. And so we have a large at of kids with hearing loss, not just unilateral, but asymmetric as well as bilateral. And then what we do with them is still a big question. And at least at our institution at St. Louis Children's, we're, in their follow-up clinics, we realize that this is a very much an underserved population, and they have lots and lots of needs. Unfortunately, sometimes parents are resistant to thinking that they need more services because they're just so happy their child has survived. And so this is an area of a lot of interest. Finally, for sensorineural hearing loss, we can't ignore the genetic components. There are quite a few syndromes that are associated with hearing loss, but not all associated with unilateral. This is a laundry list of syndromes that kids with unilateral hearing loss can have, but I want to emphasize that these are pretty rare. Probably the most common is Pendred syndrome, but it's very hard to say that it's a dominant etiology among the kids that I see in my clinic. But you have to think about these. As an otolaryngologist, got to think about this. If this is something can relate to another diagnosis in another body system, or if this is potentially going to cause progressive hearing loss or has implications for the family, then it's something that I have to think about. There are reports of families who have enlarged vestibular aqueducts or cochlear nerve aplasias. We don't have yet a genetic etiology for that. And so the genetic mutations that are now commonly tested for now with gene chips and commercial assays, even though they are very valuable in children with bilateral hearing loss, particularly the severe to profound bilateral hearing loss, they're not really helpful in the unilateral unless there is a definite familial component. And I don't want to ignore this. I'm not going to go into this very much, but certainly there are kids with a unilateral auditory neuropathy spectrum disorder, and this is mostly probably because of the absent or hypoplastic cochlear nerve, as well as kids the rare child who may have a brainstem or cerebellar tumor, as well as those with schwannomas or acoustic neuromas. Again, this is a very limited population of kids with unilateral hearing loss. So the medical workup of unilateral hearing loss starts with a good history and physical. Every medical student knows this is square one. So you want to get a complete history, find out about what happened while they were developing in utero, what happened around the time that they were born, and what happened afterward, as well as with family history. I will go a little bit more into the imaging, the lab testing, whether or not to get an EKG, and then what consultations we might get. So historically, any child who presented to the NICU and had a significant NICU stay is thought to be at risk for hearing loss. And this is true for bilateral as well as unilateral hearing loss. In general, I think it's 10 to 20-fold increase of hearing loss. And so we do definitely want to pay attention to that. As I mentioned earlier, Streptococcus pneumoniae is a big cause of bacterial meningitis and will often lead to bilateral profound sensorineural hearing loss, but it can also show up with unilateral. Mumps and measles used to be a big cause of unilateral hearing loss. Thankfully, for most populations where there is good penetration of vaccinations, that's not the case. The problem is I'm a little worried that with more people deciding not to vaccinate their kids, that this can become endemic again. Noise trauma has been a big concern, especially in teenagers, or not even teenagers anymore, just any kid who puts on headsets and earbuds, that is always a concern. So far, we haven't seen an epidemic of noise-induced hearing loss in this age group, but I think it's still early time yet to say that will be or will not be the case. Head trauma I mentioned before. And then family history of childhood or young adult hearing loss is also very important to elicit. However, what I do find is that a lot of families, parents, are not always aware of the hearing loss history in their families. They say, oh yeah, my grandparent or aunt or uncle has always warning hearing loss, but they have no idea when they started having problems with hearing. A lot of people throw their hearing aids in the drawer and never use them. And so you don't necessarily know what that history is. And so sometimes it takes a couple visits. It's like, well, could you go ask and then find out and come back and talk to me some more? So physical exam is, of course, important. You want to look for any physical signs of other problems or other abnormalities that might clue you in. There might be a syndrome. Especially the head neck exam is important. Are there any dysmorphic facial features that can clue off that maybe this is a hemifacial microsomia? You have someone who has a microtia that's mild or something like that. If you look for pigmentary abnormalities, you may pick up a child with Waardenburg syndrome. They may have eyes that are different colors, and also that would be a clue as well. Do they have neck masses, pits or tags that might clue they may have what's called a branchiotorenal syndrome? We're always looking for these signs, and fortunately, I guess that they're pretty rare, but nevertheless, that's one thing that's our task to look for. And I mentioned a little bit about the ear exam. The other important thing is, of course, especially if this is a screening situation, okay, do they have an obstructive earwax plug? Can we remove that? Is this just vernix from when they were born and we just need to clean out the ears? Or is there something more serious like a blind pouch that wasn't picked up because the ear on the outside looks normal, but you really can't see the eardrum underneath this blind pouch? And then, of course, kids who have recurrent acute otitis media or chronic miliary effusions that may still produce a significant conductive hearing loss is something that we have to watch for. So a lot of the emphasis on trying to discover etiology in sensorineural hearing loss is on imaging. And again, because so many of the causes of hearing loss for unilateral is due to inner ear abnormalities, whether we do a temporal bone MRI or a CT, right now there's a lot of discussion about that in our field. So the CT is especially good for picking up bony abnormalities, and the temporal bone is is a very dense bone. The structures are very small, and the CT has, the high-resolution CT has a very good resolution and can pick up some pretty tiny, minuscule abnormalities. The MRI is getting better in terms of its resolution and seeing small abnormalities, but it can't see the bone. It sees instead the fluid and the soft tissue. And so they're kind of almost like not mirror images, but they're complementary. And so a lot of the debate is one better than the other, and it often depends on what you're looking for. But absolutely, if we're looking for potential other causes for hearing loss rather than just the ear, then it's important for us to think about brain abnormalities. So every once in a while, we'll have a child who has a neurologic concern. They come in and they're acutely unsteady, or they have some other cognitive problems. They're not just thinking right. Then we'll want to get a brain MRI and make sure that we're not missing some impinging tumor in their brainstem. Any other child who may have other syndromes, especially you thinking, well, could this be a congenital CMV that wasn't picked up in the neonatal period? You may want to get a brain MRI and look for some distinctive changes that the neuroradiologist can tell you that are there. And then sometimes if there's a temporal bone MRI that have gotten the suggested abnormality, you want to follow up with a brain MRI to make sure you haven't missed something. So going a little bit more into details about the CT, if you get a CT on any group of children with unilateral hearing loss, somewhere between 18 to 43% of series have shown that there are positive findings. And they can vary from labyrinthitis ossificans, which is the follow-up after bacterial meningitis, enlarged vestibular aqueduct, Mondini deformity, and all these are, I'll show a few pictures of these. Labyrinthine dysplasias, where the cochlea and the semicircular canals are very odd-shaped or underdeveloped. Dilated semicircular canals, a narrow internal auditory canal, which is a sign of possible cochlear nerve abnormalities or lack of development, and of course a narrow cochlear nerve canal, which is the little canal that the nerve runs straight into the cochlea. For MRI, it seems like there are more findings, especially in kids with severe to profound unilateral hearing loss. So not as much in the kids with the mild or moderates, but in the severe to profound. It is, again, very good to rule out anything going on in the brain and to look more directly at that cochlear nerve. So there is, again, this debate whether or not to get a CT or an MRI. If you're thinking that you just want to find a temporal bone abnormality, it's still in my book CT is probably a little bit more a higher yield, but it does involve radiation. And there's a very big concern about what is the radiation dose that we're giving to kids, especially really young kids. That's less of a concern as they get older, but especially in the infant toddler age group, we're trying to avoid radiation as much as possible. However, it is a shorter exam, and so it only takes 10 to 15 minutes, and sometimes with babies you can swaddle them and they can sleep for the entire thing. If you get a little older and they're no longer in that time period where they're going to take nice long naps, then you have to sedate the kids for the MRI. And so, again, the MRI may not be as sensitive for some of the bony abnormalities. It isn't as sensitive for bony abnormalities, and we may not always find the soft tissue abnormalities that give us an etiology, again, for the mild or moderates. And so we have to balance these wishes and issues when we try to decide which to order. There is one group in Philadelphia where they're saying they can now do like a 10 to 15 minute MRI. That's something that we haven't yet gotten at Children's in St. Louis, and so we're still dealing with a 45 minute to 50 minute scanning time for the MRI. So here's just a couple of pictures. So this is showing the enlarged vestibular aqueduct, which is by far the most common bony abnormality that we see. And so in here, this is the normal vestibular aqueduct. It's very narrow. There's just a little tiny slit that you can see that's kind of gray there in amongst the white. Here, you can see a much wider vestibular aqueduct where there was a gray, and the arrow unfortunately didn't show up very well. But that's an enlarged vestibular aqueduct. There are debates as to what criteria we should use, how big it should be, but nevertheless, this is the most common reason for abnormality that we will see on CTs. On the MRI, instead of seeing really a vestibular aqueduct, we often will see what's actually a dilated endolymphatic duct or endolymphatic sac. And this is the normal side, where you see really like maybe just a little dot, but that's for the posterior semicircular canal, and you don't see anything white here against along the edge of the brainstem. Whereas in this is the dilated endolymphatic sac, and you see this little white thing that rides over the brainstem. So this is, again, a CT scan where we're looking at a narrow left internal auditory canal. So CT scans are oriented such that this is actually the right ear and this is the left ear. So this is normal. So this is the cochlea. And you can see there's actually a little canal that you can see going into the base of the cochlea. Here, and this is the normal size of the internal auditory canal right here. And this one, you can see that it's more funnel-shaped. It seems to narrow. And this is not a really good cut. But if you went to find the cochlea, you would see that there's probably not a cochlear canal there. On the MRI, we can more directly visualize whether there is a cochlear nerve or not. And so, again, this is the right ear. And unfortunately, I don't have the scans to go up and down because it's hard to replicate. But you get the sense that the cochlear nerve comes in and it goes straight into the cochlea, whereas on this side, it seems to be missing on the left ear. And this is supposed to have 4 little dots, 1, 2, 3, 4, and so you can see only 3 here. And so that is the diagnosis of a left absent cochlear nerve. And I'm sorry for the graininess of this view, but this also shows a large abnormality in both the cochlea and the vestibules, or the semicircular canals, where there is just a large area of like a mush, where there ought to be some nice distinct bony partitions and canals. So among children with bilateral hearing loss, use of the EKG was thought to be a very simple and quick way to make sure we eliminate the possibility of the long QT syndrome and a very lethal diagnosis. So the Jervellen-Lange-Nielsen syndrome is known to be quite lethal in young children. But however, it's found that this is really a profound bilateral sensorineural hearing loss presentation only. So it really does not show up in kids with unilateral hearing loss. There is a heterogeneous syndrome called Romano-Ward, which does not seem to be associated with unilateral hearing loss. And so it's really not very helpful. And so it's something that I've stopped doing, basically. Now, urinalysis or urine culture, however, is important because that's one way to diagnose a current CMV infection. And so this, especially if we are seeing a young child, especially a newborn within the first 3 weeks of life, then that'll be one of the first things that I will do. Unfortunately, often I don't see these kids until they've already had their diagnostic ABR. So they're 1, 2, 3 months old. And so then it's not easy to say, well, even if that was positive, that it's helpful. But I will talk a little bit more about a strategy that we use to try to rule it out and help figure things out there. Hematuria and proteinuria, so that's blood and protein in the urine, are features of syndromes with hearing loss that often present in teenage years, and so we don't see a whole lot of. There are other urine tests like looking for calcium and an alkaline urine that is, again, associated usually in kids with kidney diseases that are associated with hearing loss, but they, again, usually present in the teenage years. And then, but they every so often may see a child who kind of looks funny, and as you follow them over time, they may continue to look funnier, and they may have Hunter or Hurley syndrome called a mucopolysaccharidosis, and so that's a congenital problem where they deposit these mucopolysaccharides. They're not able to get rid of them. They deposit in various parts of their body, and then they have then very obvious physical findings as they grow older, and they may have hearing loss, including unilateral hearing loss. Blood tests can be helpful, but not as much. Again, usually if we're looking for thalassemia or sickle cell disease for the vast majority of states in the U.S., that's already being screened, and so that's not as helpful as it used to be, say, 20 years ago. Again, looking for abnormalities in CBC may be associated with Alport syndrome. I will say that I did once pick up a child who had a leukemia, who had a very, very high white count based on his CBC, but that's the only time since I was a resident, so it's more than 20 years now. Again, the urea and electrolyte abnormalities are associated with Alport syndrome, but again, that's usually an older group of kids. And then what I will often get, though, are specific immunoglobulins, again, depending on the patient's history and concerns. So the congenital cytomegalovirus, if it's still there and you have a child who is an infant, they are still shedding virus in their urine and in the saliva. But if they're older than that, they may not be shedding virus anymore, and then the only way you can tell where they've been exposed is to test their blood for immunoglobulins. And so if you look for IgG or IgM, you can tell whether they've had a recent or a more distant infection. Rubella, HSV, and syphilis are also possible congenital infections that can cause hearing loss, but it's very much more on a case-by-case basis as whether or not we would do those blood tests. Thyroid tests were thought to be very important before we had some gene tests for Pendred syndrome. It's not as often done. And again, it used to be that with congenital hypothyroidism that you might have some hearing loss, but again, I think the vast majority of babies in the U.S. are now being screened for it at birth, and so they're being picked up, and we're not seeing them as much in clinic without a previous diagnosis. An autoimmune workup is actually pretty important, I think, in older kids. I've picked up several kids, older kids, teenagers, who've had autoimmune problems and will present with a sudden hearing loss. And so in this situation, starting them on steroid medications, getting them in to see a rheumatologist is important, because then we can sometimes halt the progression, once in a while reverse the hearing loss, and actually make a difference. Genetic testing is an area, as I mentioned from the very beginning, there are a lot of genetic tests out there now. This is an area that has been revolutionized for bilateral hearing loss over the past 20 years. However, we don't have a gene that we know is specifically associated with unilateral hearing loss, and so the vast majority of kids, we're not going to get a genetic test unless we know that there's other family members who have been who have had a syndrome or are known to have a genetic hearing loss. The consultations that we'll get are almost always ophthalmology and occasionally genetic. And ophthalmology, as Lori mentioned earlier, there's a lot of audiovisual integration that goes on. We think that's so important that even if the hearing is not optimized, that we could optimize the vision. And up to half of kids with a hearing loss will have refractive errors. And so putting on a pair of glasses is relatively easy and painless compared to even trying to put on a hearing aid. And so this is something that we talk to all parents about. Every once in a while, then we'll have a child who will also have a retinal problem that will be picked up by an ophthalmologist. And again, that's very rare, but it does happen from time to time. So this is a diagram from a paper published about 10 years ago showing that with all of the rubric of what's been done for bilateral hearing loss, this is where unilateral comes in. And so even 10 years ago, it was thought that the CT scan would be the first place to go and consider GJB2 a screen. This is less something that I would do, but definitely preferential seating in classrooms and looking at serial audiograms to look for progression is something that we would still do. So this is my most current testing algorithm for children with unilateral hearing loss. And this is something that I probably need to talk a little bit more about with our other pediatric otolaryngologists across the country. But in recent meetings from when we were just in Dallas at a national meeting, and as well as one in Boston in the spring. It seems like this is a lot of what the otolaryngologists across the country are doing now. So if you have a neonate or an infant, we are all thinking about testing for CMV. Again, a child who has born with CMV should be shedding CMV in their urine or saliva for at least a couple of years. And so if they're shedding, there's a good chance that they might have congenital CMV. And then testing for the immunoglobulins. The reason why that's important is because we actually have treatment for it. It doesn't mean that it's something we can do long term. There's still a lot of research going on. Nevertheless, it's something that we can potentially do something about and even reverse. If there's a profound hearing loss and they're young and still can be swaddled and put to sleep, or they can be kept asleep while they're swaddled, then get an MRI early so that we can see whether or not they have a cochlear nerve aplasia. It's harder to do. It's harder to recommend for that for a child with mild, moderate, or especially if we're thinking that maybe a CT would be higher yield, just because of the radiation considerations. So I would put that off. And if there's anything on the physical exam that suggests a syndrome, think about a genetics consult. For a child, so anywhere from preschool age to maybe kindergarten or first grade, again, CMV, I'm going to look for immunoglobulins to see if they've been exposed. What's nice, it's hard to say that they do or do not have congenital CMV if it's positive. However, if it's negative, that means we get the test and the test is negative. At least you can rule that out as a potential cause. And I think that's important because of the prognostic implications, that children with CMV are prone to having progressive hearing loss and that it gets worse over time. And I think that's important knowledge for parents to have. We would get a CT or MRI if the hearing loss progresses or if there are other symptoms. And that's only because, again, we're balancing the risk of radiation or sedation against the need to know or the benefit of knowing what the etiology might be. For older child or teen who can hold still for the duration of the CT or MRI, then a CT or MRI is something that I would recommend and routinely order. But again, it depends on the level of the hearing loss, and sometimes it's what their insurance will pay for, unfortunately. And then definitely for really all children, get an ophthalmology consult and then consider genetics testing or consult.
Well, I'm a parent. I have a 6-year-old who's a unilateral, and he's sensorineural. So one of the questions that I have is, you mentioned blood tests. I guess I wasn't told, but I do have a family history of thalassemia. I don't have it myself, but my grandmother has it. And I wasn't sure if, I guess, having a CBC would be great for my son to kind of see and rule out if that's a etiology. We did do a genetic consult and CT, and everything's negative. We don't have any family history of hearing loss or anything like that. So. And of course, we don't want to do you mentioned the MRI because he's at a young age. So for us, it's not as important to kind of pursue the MRI. But you mentioned about the CBC, and I just thought about that I do have a family history of thalassemia. So do you think that may be
I mean, a CBC is very quick and easy, and it's just a little prick. But I would be surprised if he didn't have the screening done already. Most states do, especially if he's 6. Yeah. But that's certainly something that it would be again quick and easy, and you can find out. Yes, there. There's some. All right.
Thank you. I have a question for clarification on the genetics consults that you're speaking to. I'm an adult with sensorineural hearing loss.
Yeah.
So it's a personal interest. But with children, what does the genetic consult possibly do? Because as an adult, I was told not much could be done, so I didn't opt for that route. Can you explain the difference?
So for adults, it's usually thought that it's an acquired hearing loss. And again, it depends on how old you were when you developed your hearing loss. And so in that situation, genetics is not usually thought to be as helpful unless there was a strong family history of hearing loss, especially at a younger age. Whereas for kids, if they have a hearing loss, and especially if it's associated with some other syndrome, or if it is associated with enlarged vestibular aqueduct, more of us are thinking about doing testing for Pendred syndrome, which doesn't show up very soon. It's not until they're a lot older, and that could have implications for younger siblings. For instance, I had a family where I saw, I think she was 6 or 7. She had enlarged vestibular aqueducts and also profound hearing loss on one side. And then several years later, I saw her 3-year-old sister who had the exact same thing. And I wanted them to get genetic testing. The parents refused. But it's something that, we do have that discussion.
I have 2 quick questions. One is, what's the upper age limit that you can do the blood tests for the CMV, the IgG, and the IgM?
So there is no
That
upper
shows
limit. There is no upper limit. For instance, if I see a teenager, it would be an easy blood test to do and to see if they've been exposed. The problem is that CMV infection is really common. And so if you haven't had it, if you don't have it when you're younger, and you haven't been diagnosed when you're younger, it's very possible that you've been exposed at some time during your childhood, and it could have been a very, very mild illness. And so you could be positive, and so it doesn't help if it's positive. It only helps if it's negative, as an older child.
Okay. The other question I have is, are you seeing a trend with permanent unilateral hearing loss not due to middle ear effusion? I've diagnosed many more children with unilateral hearing loss in the last year or so than I've ever seen before.
Part of, I think, the explosion of diagnoses of unilateral hearing loss is that we have hearing screening now. And that's across the country. And so that was actually one of the motivations for me to get into this whole investigation of this area is in Missouri and Illinois, the state laws mandated newborn hearing screening in 2002. And so then all of a sudden you see all of these babies coming in with this diagnosis, and I didn't know what to do. And so looked into the literature, realized there were some studies, and I'll go into this a little bit, in my next talk, about some issues that were discovered in the 80s and the 90s, but I think they didn't rise to the level of visibility for many of us in otolaryngology, and so that's what led to me going into this area.
So in Washington State, they keep the neonatal blood spots for, I think, 21 years. So we do a lot of our CMV testing from looking for viral DNA in the blood spot. I was just wondering, in Missouri, do they not keep it very, very long, or is it not available to you?
Yeah, so they are available for 5 years. There are some obstacles in that. The parents have to request them, and then the parents have to deliver them to you to get tested. And the difficulty is that I know Kathy knows about this, is that the sensitivity, the ability to pick up CMV from a dried blood spot is only about 33%. So it's not very sensitive.
Yeah, that's too bad. You think in Washington they send it. They actually will mail the blood spot to the lab here now, which is nice. But it's like you say, it's another of these tests where, if it's positive, it's the reverse of the serology, which is if it's positive, it's good.
If it's positive, it's very helpful,
right? If it's
right?
negative, it's not.
But the problem is that it also takes time, and so then if you have a child that you think might have congenital CMV, do you wait until that PCR is back, or do you go ahead and start treating? I mean, that's another dilemma that we have. I'm sorry, there's a question up in front here.
I just want to clarify, because I do have a child who has CMV and a unilateral hearing loss. And many people say, the mother says you should go to the doctor, get tested, but they always say that they'll get better. But you just mentioned that it's possible for the hearing loss to get worse. I'm getting mixed messages. We were informed that the child was going to get better, but you just said that it would worsen. So could you elaborate?
So I think the main concern is if the child has a congenital infection, that is, they were born with the CMV infection. Then this gets into two different categories, whether they had other symptoms of CMV when they were born, or if they had no other symptoms of CMV when they were born. Regardless, any child who's born, no symptoms. So any child who is born with a congenital CMV infection is at risk for hearing loss and progression over time. So that there were protocols that suggested up to age 6 they can progress. It seems like now age 9 they can still progress. So I don't know that we have come to an upper limit when they're no longer at risk for hearing loss. And certainly once they've been diagnosed with a hearing loss, that hearing loss can get worse over time.
Can I just comment on the CMV issue, because we've thought about this a lot, and the issue, just for everyone's information, is that in order for a baby to have CMV-related hearing loss, the mother has to have had the infection while she was pregnant with the baby. And if you have a CMV exposure or infection anytime after birth, it's not thought to be associated with hearing loss. So because 40 to 75% of women have been exposed to CMV, even if they have CMV in their breast milk and they're feeding their baby, the babies can become positive after birth, even at very young ages. Mm-hmm. And so that's the trick, and that's the nice thing about the newborn blood spot, is that they get them usually within the first day of life. But everything, the more detailed you get, the more muddy things get. Dr. Liu brought up the sensitivity issue that, you can have false negatives. It's unlikely to have a false positive. And the false negative rate, though, depends on what kind of paper it's on, what kind of extraction techniques you use, how old the blood spot is. And so all these factors kind of come into play. So it is complicated. Mm-hmm. And I think the serologies can be helpful if they're negative, so that if the kids don't have any immunoglobulins to CMV, that means their system has not seen CMV. So that's good. I think the trick, and we see this quite often actually, is that people send serologies, they come back positive, and then everyone says, oh, they have CMV. Yeah, it's kind of true and unrelated. Yes, they've been exposed to CMV, but the serologies will never tell you if they were exposed to the CMV in utero at the time when they have to have had the infection. So it's complicated. Consult your physician. I think that as far as your child and your question about whether it might get better, some kids have fluid in their ears, thought not to be related to definitely not related to CMV. Maybe that might get better. So every child is different. We don't want to give any medical advice for any particular child, but those might be some of the factors considered.
Yeah, Dr. C brings up very important points that, and it is a very complex and nuanced situation. And I think the management, how we deal with these kids with CMV or diagnose them even, is evolving. So you have to stay tuned. Sorry. Okay.
Do you know if there have been any studies or have any thoughts as to why sometimes CMV manifests as a unilateral hearing loss versus bilateral, or what the mechanisms are for that?
That's a great question, and I don't know that anyone has an answer for it. From the epidemiologic studies, children who have symptomatic congenital CMV are more likely to have bilateral hearing loss. Children with asymptomatic CMV infections are more likely to have unilateral hearing loss. So why that occurs, I'm sure there is some complex interplay with the immune system, cochlear immunology. It's not clear. Yeah. Great, thank you.